Welcome to this Advanced Heart Preservation webinar. I'd like to thank you for taking the time out of your busy schedules to join us for this event.
I am Yasuhiro Shudo, the Clinical Assistant Professor, Department of Cardiothoracic Surgery, Stanford University. On the other hand, the Paragonix SherpaPak cardiac transport system, as shown here, is the ultra-portable hypothermic preservation and transport system. Improvement in the preservation and transportation conditions has the potential to improve organ quality at the time of transplant, optimize patient outcome, and prolong the acceptable maximum allograft ischemic time. So technically, it's quite simple. So briefly, first, secure the heart connector with the ascending aorta of the procured heart. In Stanford University, we have been having a favorable experience with SherpaPak cardiac transport system since we first used this system here in July 2020. We have reported our successful experience as case report with the longest reported storage period of the 283 minutes in our knowledge, and then the allograft ischemic time of 360 minutes. So in our impressions, especially for the case with relatively longer allograft ischemic time, such as more than 4 hours, this system can potentially help to regain the atrioventricular conduction and normal sinus rhythm quicker, recover cardiac functions, potentially reduce required reperfusion time, and eventually reduce the chance of primary graft dysfunctions. Thank you very much for your attention.
And my topic is to cover the ISHLT consensus statement and also the National SherpaPak sharing program in the UK, which we are working on. I'm a cardiac surgeon and the director of transplant program in Manchester in the UK. So we go straight to this consensus statement, which was published earlier this year, which is a heart and lung procurement. I'm proud to be one of the authors of this paper. And we know that ischemic storage is beneficial. However, it can also cause quite a deleterious effect on the organs. So we looked at, this is a paper just published yesterday. We looked at our outcome, the financial implication, and the outcome of patients who need veno-arterial ECMO for severe PGD post-heart transplant in our unit. So we also noted that the cost implication was phenomenal. It's over double. So this is where the ISHLT consensus statement comes. An ideal temperature for heart is probably around 5 to 10 degrees centigrade. So that means most of the time, the ice box, we are probably cooling the heart too much. And also the consensus statement recognizes there are new technologies for packaging to prevent the freeze-related injury. And that's where the Paragonix SherpaPak comes. We adopted this technology in 2019, December. It's been 12 months since we have started using this. The recipient age is 50. We had equal number of ischemic and dilated cardiomyopathy patients. Our median ischemic time is 180 minutes, but our longest was 4 hours, 20 minutes. It's 260 minutes. So coming to the National Retrieval Service and sharing of the Sherpa, there are 5 centers in England and 1 in Scotland. What our plan is to start actually sharing these hearts using the SherpaPak, which means if Harefield retrieves the heart for Manchester, they use a Sherpa, and then we actually send a fresh, unopened kit to them. So our aim is to start sharing the Sherpa so that we don't have to send our team to get the heart, which means we can use the long ischemic times without having to send our team out.
Yes, we are quite excited in Harefield, and a warm welcome. Second center in the UK, together with Manchester, we are really excited about the introduction. And Harefield has a specific different situation. And I would like to show you two little videos which gave us an incentive to change, and at least to look, not completely, but to look into alternatives to organ care system. And of course, this is a video sequence 2 hours afterwards, and I was just stepping out of the hospital to have a look at the system in order to say, are we going to pursue with the transplantation? And now have a look at the heart 2 hours later. And I was so what you see, the left ventricle wasn't really some kind of impressive, even so lactate values were good. This was our final incentive to look for the alternative. And interestingly, a day later, we had an offer, and this was the first SherpaPak run in September. So we were about 9 months behind Manchester. Come after 137 minutes ischemia time. Heart was starting immediately. And what is something striking, when I first was introduced by Paragonix with the system, there was some kind of an advertisement movie from the MGH, and the surgeon who implanted the first system said, well, the heart looks very soft. And indeed, this is my impression as well. When you release the cross clamps, the heart is very soft and starts immediately beating. And this was a quite impressive, for not only me, for the entire team, impressive moment. Since September, we have done 5 SherpaPak runs. We started with a very quick 137 minutes. We increased to 264 minutes. Unfortunately, one patient died of an intracranial bleed unrelated to the SherpaPak. We had 0% of primary graft failure, and we are quite excited to continue the use of the SherpaPak.
Outstanding. Well, first of all, I'd like to thank the crew from Paragonix from having me on this webinar to join this incredible panel of speakers. And I enjoyed the 3 previous talks. And we looked at 24 consecutive patients who underwent cardiac transplantation using the Sherpa system over a 1-year period, starting with our first case on August 19th, 2019, and looking at all the cases starting within 1 year of the first case. Of these 24 cases, 12 of these are children, which we define as patients less than 18 years of age. And I'm going to review first our overall experience, and then after that, I will focus on the children. From that slide, we can plot out the temperature spread and the average temperature of all of these different transplants. And if we look specifically at some numbers for the overall series, the average temperature during preservation was 5.8 degrees, with a minimum and a maximum of 5 and 6 degrees, and an average spread of 1.24 degrees. I think those are data that's probably a substantial improvement from putting the heart in a Ziploc bag and putting that in a bucket of ice and then putting it in an igloo cooler. Now let's focus on the pediatric experience. Half of these patients were children. And here again is very similar data looking at the average temperature and the temperature spread. And this just shows that the temperature information on the pediatric donors is basically identical to the overall series. The clinical results from this experience, well, today, 6 months from the end of the series and 1.5 years from the start of the series, all 24 of these patients are alive and well. We had 0 cases of graft dysfunction, 0 cases of post-transplant ECMO, and 0 cases of post-transplant ventricular assist devices, which tells us that this transportation system certainly allowed for stable transportation and preservation of both the adult and the pediatric heart.
Have any of your centers done similar studies with your previous methods of storage?
It's funny because our team this morning on rounds, we were discussing this presentation and that very question came up. Have we done any comparisons to prove, does this really make a difference? And, you know, obviously the best way to do a study like that would be to randomize matched patients to Sherpa versus no Sherpa, and then to see what the outcomes were. But and we talked about this on rounds, and I think the general consensus of our team that there's clearly not equipoise to do a randomization like that when all of us are convinced in our own minds that this is so much better.
Yeah, I think I agree with that comment, because the more and more you start using SherpaPak, especially 5 out of our 9 transplant or VAD explants to transplant, and you feel the heart coming out without any shocking needed, with a very early return to sinus rhythm, very early weaning of the inotropic support, you almost feel that I'm not doing the transplant if I don't have a SherpaPak. So it is, some of my colleagues have already said I've never seen a right ventricle this good immediately after releasing nearly 200 minutes of ischemic time. So we'll be into the difficult situation. That's why some way or other, we have to get, with all the data available, we don't have to probably put through another randomized trial. We have to find a way to get this commissioned, especially in the United Kingdom.
Many thanks to the expert panel for 4 incredible presentations, and thank you very much for joining. Happy holidays, and we wish you a great start into the new year.